Good afternoon, everyone. Today, my talk is on oxygenation in patients who are hypoxic and have got either severe or critical COVID. Now, to talk about oxygenation, it's not enough to talk about oxygen administration as we normally used to do in the good old days. But now, in an era where we live, wherein oxygen is an extremely scarce resource, it's also important to talk about oxygen conservation. So I've divided my talk into two parts. One, on the right way to administer oxygen, and two, is a little bit more practical on how we can conserve the limited oxygen resource that we have to benefit the maximum number of patients that we are currently having in our hospitals. To understand the best way to give oxygen, we need to get an idea of a concept called peak inspiratory flow. So the graph clearly shows that most people who are breathing at about 10 times a minute, spending about 1/3 of the respiratory cycle, which is about 2 seconds in inspiration, take an inspiratory flow of about 30 liters per minute. In other words, you and I sitting here breathing normally, when we take a breath, the breath that we take, the flows reach as high as 30 liters per minute. This is normal people. Now, if somebody like this were to fall sick and become extremely distressed, the peak inspiratory flow rates can go up to 50 to 60 liters per minute. Now, what does this mean when I say somebody's inspiratory flow, the peak flow reaches 30 liters or 60 liters per minute? What it means is that if somebody is breathing at 30 liters per minute and we are only delivering oxygen at 15 liters per minute, then where does the remaining 15 liters come from? It comes from air. So in other words, the oxygen that we're giving gets diluted with air and we are unable to reach high oxygen concentrations. Now, this key point wherein we understand the relationship between the peak inspiratory flow of patient and the oxygen flow that we deliver allows us to classify devices into two types. One is a variable performance device, another one is a fixed performance device. So a fixed performance device gives flows that are equal to or higher than the patient's peak inspiratory flow. In other words, the oxygen concentration is fixed. The classic example of this is the high flow nasal cannula. Whereas other devices like the standard nasal cannula or the simple face masks give oxygen at a fixed flow. It will not meet the patient's peak inspiratory flow, and the excess, in other words, the patient is breathing at 40 liters per minute peak inspiratory flow and we're only giving 10 liters per minute. The remaining 30 liters per minute, which is the difference between the two, is made up by breathing in air. So if you look at the reservoir bag here, this is one way of giving high oxygen concentrations while at the same time conserving the amount of oxygen that we use. This is one of my favorite devices now, and it's very important to use this device properly. So this is a non-rebreathing bag. So the blue arrow shows oxygen, and so oxygen that is coming in goes in and fills the reservoir bag. Before putting this device onto the patient, it's important to use one of your fingers to occlude the device where you can see the blue arrow where the reservoir bag meets the mask. Make sure that the bag is filled up to about 500 mLs of oxygen and only then put it on the patient. And now when a patient takes breath, the reservoir bag will empty and oxygen enters into the patient's respiratory tract. And when the patient breathes out, a valve closes at this point so that none of the air the patient is breathing out will enter the reservoir bag and the air goes out on both sides where the blue arrows are showing the air goes out without mixing with the oxygen that's coming in. That's why it's called a non-rebreathing bag. This is currently my favorite device to use in patients who are sick and needing more than 50 to 60% oxygen because the reservoir bag allows me to meet the patient's peak inspiratory flow without me setting very high oxygen flows on my oxygen meters or using high flow cannulas. And this allows me to conserve oxygen. So how do we use our variable and fixed performance devices? So somebody comes in, oxygen saturation is a bit low. So initially when the COVID crisis started off, I was giving oxygen to anybody whose oxygen saturation was less than 94. But now we know that oxygen is a scarce resource and we need to be more careful in using oxygen. So now I watch them and I use them if they're needing oxygen saturation or if their oxygen saturation is 90% or less. I'm accepting a different threshold. We'll discuss that a little bit later. The initial one that I reach for is a nasal cannula, which is extremely well tolerated because it just covers the nose. Patient can continue to talk and continue to eat in an uninterrupted fashion. But the maximum flow we can give through a nasal cannula is about 4 liters, and the maximum oxygen concentration is about 40% that we can give through a nasal cannula. If despite nasal cannula, the patient continues to desaturate, oxygen saturation levels are, we are struggling to reach oxygen saturation levels of 88 to 90, then we change over to the simple mask, which we can give up to 10 liters per minute, and this can give a slightly higher oxygen concentration of about 50 to 60% oxygen. Despite a face mask, which if the patient continues to desaturate, then I reach out for the non-rebreathing mask. Now, previously, when oxygen supply was not an issue, my favorite device used to be the high flow nasal oxygen. But if you look at this graph, a non-rebreathing mask gives about 70 to 90% oxygen while consuming 15 liters of oxygen. Whereas the high flow nasal cannula, which can meet the most demanding patient's peak inspiratory flow, uses up to 70 liters per minute of oxygen. Now, if you have 2, 3, 4 high flow nasal oxygen cannula devices running, believe me, the burnout of oxygen is going to be very high, and we're going to be stressing our limited oxygen resources. So in the current era, I would strongly recommend minimizing the use of high flow nasal oxygen cannula. Now, despite the patient being on HFNC, despite the patient being on non-rebreathing mask, if they continue to desaturate, then now my go-to device is I bypass the HFNC and go to a CPAP device. So if you have a dedicated CPAP device with a well-fitting mask, then this is what we can use. If you have a device that provides BiPAP, then we can continue to provide PEEP. Please put your IPAP or pressure support, whichever mode you're using, at 0, so patient only gets CPAP. Now in CPAP devices, we can still continue to provide 100% oxygen through an appropriately fitting mask. Now, how do we recognize that our patients are not getting better and they continue to worsen? For me, a key concept is, one, how much FiO2 are we giving? The higher range of FiO2, once people start needing more than 70-80% oxygen, I start to worry about them. Once on 70-80% oxygen, the SATs are 85 or less, I start to worry about them. But the key thing I'm thinking about is, what is their work of breathing? The work of breathing is calculated by measuring the pressure that is required to generate a tidal volume. Now, there's no way we can work this out on most of our patients without access to spirometers. So we have to use a combination of symptoms and signs. So classically, the first response to hypoxia is tachypnea. The respiratory rate starts to go up, and it's not uncommon to see people with COVID breathing 35 to 40 times a minute as they start to try and push more oxygen across their damaged lungs. The first sign is invariably tachypnea. Then I look at two things. What is the patient saying? What is the patient doing? When I talk to them, I see they're able to talk in complete sentences. Very often they stop midway, take a breath, and then complete the sentence. So this is a worrying sign. The other thing I look for is what they say. They say, I'm comfortable and I'm at rest, but the moment I do the slightest movement, even just turning myself as I prone or turn laterally, as I sit forward, as I eat, as I take my mask off, I start to gasp. This is a very worrying sign, which means they have almost no reserve at all. The slightest stress causes them to become distressed. The other signs that I look at and I worry about are when they start using their axillary muscles. So you can see them, their abdomen is heaving up and down. You can touch their trachea and see their trachea is moving up and down. And this tracheal tug is a sign that they are going to start tiring soon. The tracheal tug happens because the diaphragm is working overtime. It is really moving downwards, contracting strongly and moving the entire mediastinum downwards. And trachea is connected to the lungs of the mediastinum. And the tracheal tug is a sign of extreme diaphragmatic effort. The other thing to look for is use of axillary muscles. So if you feel the sternocleidomastoid as they're sitting down, you'll find there is phasic contraction. Every time they take a deep breath, the axillary muscle, the sternocleidomastoid is contracting. You can actually feel it. And this is called a respiratory pulse. It's almost like as if you're feeling the carotid pulse, but actually the sternocleidomastoid is phasically contracting as they struggle to breathe more and more. And drowsiness and increasing carbon dioxide are extremely late signs, and you must intervene with intubation before the patient gets to that stage. So when you look at oxygen delivery, we spoke about oxygen delivery devices. We need to talk about how to start conserving oxygen. So we need to look at how much oxygen is being consumed when we look at various devices. So nasal cannula is pretty straightforward. The oxygen that's being consumed is what you set. Set 1 to 5 liters per minute, that's what's going to be consumed. On a face mask, once again, it's fairly straightforward. what you set is what's being consumed. So you set it at 5 liters, 5 liters of oxygen is going to be consumed per minute. You set it at 10 liters per minute. The non-rebreathing bag consumes about whatever you set once again. We set it at anywhere between 10 to 15 liters per minute, and that's what's being consumed. But how do we work out how much oxygen is being consumed on the ventilator, on the high flow nasal or cannula, or CPAP devices? On the ventilator, we need to look at a couple of things. The minute ventilation of the patient determines how much oxygen is being consumed. So somebody who is on the ventilator receiving a minute ventilation of about 12 liters per minute or consuming that much, then at an FiO2 of 1, which is in other words 100% oxygen, then they're consuming 12 liters per minute. In addition to the 12 liters per minute, depending on the ventilator, we're talking about the invasive ventilation mode now, we need to look at the bias flow. There is always a continuous flow in ventilator machines. This is for the ventilator to decide and recognize when a patient is taking a respiratory effort to support it. So the bias flow in the Mackie ventilators is what we use is about 2.5 to 3 liters. So somebody on 100% oxygen on a minute ventilation of 12 liters with a bias flow of about 3 liters is going to use about 15 liters per minute of oxygen on a ventilator when the patient is intubated. The high flow nasal cannula, so this is worked out here. If somebody is on 100% oxygen through the high flow nasal cannula and you're giving 40 liters per minute, then you're using 40 liters of oxygen per minute. Once again on CPAP, if you're using something like 12 liters per minute ventilation, which is displayed on the machine, then if you say there is a leak of about 50 to 60%, normally we aim for a leak of about 20 to 30%, but sometimes the leak can be up to 50 to 60%, then an additional 8 liters are used and the CPAP consumes about 20 liters per minute of oxygen. So if you look at it, the high flow nasal cannula giving 40% oxygen consumes still 2 to 3 times what an invasive ventilator or a CPAP would consume. So in other words, when we are in an oxygen conserving mode, when our oxygen supplies are always precarious, then there is almost no role for using the high flow nasal cannula. When I say no role, I do not mean clinically. Clinically, I still think they're great devices. I think we have to stop using them purely on grounds of conserving the oxygen that we have. So this is a way for calculating oxygen consumption. So if you know the flow, for example, you're using high flow nasal oxygen, you're giving an FiO2 of 60% and your flow is 60 liters per minute, how much oxygen you're consuming? So a quick calculation would be 60 minus 20 is about 40, 40 by 80 is about 0.5, and your flow is 60 liters per minute, then you're using about 30 liters per minute of oxygen. So this formula helps you calculate your oxygen consumption when you know the flow and the FiO2. So an high flow nasal cannula at about 60 liters per minute using 60% oxygen still uses about 30 liters per minute, which is still quite higher, several times higher than what you'd use during invasive ventilation or CPAP. So how do we go about conserving oxygen? So be cautious, be extremely cautious with high flow nasal cannula. I have almost completely stopped using high flow nasal cannula in our unit, unless for extremely rare patients where I know that this patient is going to benefit only from high flow nasal cannula. But once again, I try and minimize the usage. The second way is to target much lower oxygen saturations. We'll discuss this in a minute. Utilizing oxygen concentrators. So most hospitals almost never used oxygen concentrators. We never used oxygen concentrators in a hospital. But following the challenges we are having with procuring oxygen, we have procured at least 12 oxygen concentrators that I can think of. They're high flow ones, 10 liters per minute. And now we are using them inside the hospital to conserve our oxygen for those who need it desperately on either CPAP or ventilator modes or non-rebreathing bags. The other thing to do is when our patients are on CPAP or NIV modes, please ensure that you're using the appropriate size mask to minimize the leak. A significant leak can significantly increase the amount of oxygen that is being wasted. So this is not even going to the patient. This oxygen is being wasted, it's just entering the environment. And the most important thing is to use the appropriate fitting mask to ensure that leaks are at minimum. The next thing to do is to eliminate system leaks. System leaks can happen at various places. If you have not maintained our oxygen flow system for a long time, then they can leak at various parts from the cylinders, from your oxygen generators, from your liquid oxygen, from the source to the endpoint. They can leak anywhere. So please have your maintenance team look at it again. Another thing that happens is sometimes we see the nurses put oxygen flow on and it's at 15 liters per minute, but it's not actually 15 liters per minute. It is turned so much anti-clockwise that even though it is showing 15 liters per minute, we can be using 20, 25, or even 30 liters per minute. We cannot measure it because once we go about 15 liters per minute, if the device, the knob is turned on excessively anti-clockwise direction, we can be still using a lot more, and this could be another source of wastage of oxygen. Another thing I find is patients are on oxygen intermittently. So when the patient's oxygen devices are on, the oxygen flow meter is on. So we must religiously turn off these oxygen flow meters. But we are not there all the time, so it's very much important to emphasize this to our nursing staff, to try and minimize oxygen use as much as we can. So this is one way of using the appropriate fitting NIV mask to use a measuring device like this. A simple thing which comes in with packed in with every mask, and we need to use one that sits on the bridge of the nose comfortably at the top and does not sit either too close to the lips or beyond the chin, but midway between the lips and chin. Okay, so oxygen saturation, what oxygen saturation to aim for? Let us start at the extremes. So this was from a study that was done about 10 years back by a bunch of doctors who decided to climb Mount Everest, and they measured their oxygen levels. This makes extremely interesting reading. So they reached the top of Mount Everest. There was no way that they could do this study there. So they come around another 500 meters down, and at an altitude of 8,400 meters, they take off their cold gear and stick the ABG syringe into the femoral artery, take a sample, barely manage to make it back to the next camp, and then they send their blood gases to be tested and look at their partial pressure of oxygen. Extraordinary. The lowest PaO2 of 19.1. I don't think you can record anything less than this in a living subject. So their average PaO2 is about 24 millimeters of mercury. Incredible. Shows how human body adapts to endurance at extremes. But remember, these are extremely fit people, and they have gradually acclimatized themselves to climb the Mount Everest. Their saturation levels on average are about 50%. These are not, I'm not suggesting in any way that these are targets that we should aim for, but I'm just saying how the body adapts at extremes and manages to do with very low oxygen saturations. But it's important to remember that these are people who are extremely fit and have trained for over 40 days, the minimum to start from base camp to reach the top of Mount Everest. And these are not things that we should aim for. But I just thought it's very interesting to see how the human body can adapt to extremes. Now, if you look at the studies that are done in patients at more boring atmospheric levels, the ones you and I see in our ICUs every day, there are a number of studies that have been done. The latest one is the hot ICU study, which compared two groups of patients. One group of patients who were given conservative oxygen therapy, and the other group of patients that were given liberal oxygen therapy. So the conservative oxygen therapy in hot ICU trial, at least the PaO2 they aim for was 60 millimeters of mercury. Remember that anything less than 60 millimeters of mercury is considered as respiratory failure. And in the liberal group, the target PaO2 was 90 millimeters of mercury. And there was no difference between the two groups. Now we can't really be doing blood gases for all patients. So what does a PaO2 of 60 translate as? A PaO2 of 60 translates to an oxygen saturation of about 90. This is a meta-analysis of all the studies that have been done. And all the studies that have been done shows conservative oxygen therapy does not cause harm. So in other words, aiming for a lower oxygen saturation does not cause harm. So what oxygen saturation target to aim for? In the hot ICU trial, on average, the saturations for the people in the conservative groups was about 96, whereas in the liberal group was 96, 97. So 92% we're all quite comfortable with. I think we should, if we are giving oxygen, we should aim for a saturation of 90%. If the patient is not on oxygen and the saturation is 95, 96, and so be it. But if we are giving oxygen, there must be accompanied by clear instructions to the nurse to target oxygen saturations of 90% plus or minus 2. So in other words, we are going for COPD targets, which are the old COPD targets, 88 to 92. And if the saturations are consistently above 90, I would even question the need for giving oxygen to these patients. So now I'll move on to oxygen concentrators. This is something that we never even looked at before, but now we are using at least a dozen of these in our hospitals, currently being used to conserve our limited oxygen flows. To buy these, all devices must have an oxygen flow meters. They usually come in two forms, 5 liters ones and 10 liters per minute ones. The 5 liters per minute are usually used for stepped down patients. So we have had somebody who's gone through the worst, but is getting better, but taking time getting better, and is now on minimal oxygen. So just give them 5 liters per minute, move them out from the high dependence area, ICU areas, move them to the wards, move them to even the non-COVID wards if they've crossed, they're no longer considered infective, so that you can utilize these areas for the sick ones that are coming in. The oxygen concentrators for 10 liters per minute are much more useful for hospitalized patients. So they come in, you're struggling to find a place to put them in, any bed with or without oxygen. All you need is a plug point and a portable pulse oximeter and a nurse that's going to go around and check their saturations regularly. Use a 10 liters per minute one and connect them to the non-rebreathing mask and watch their oxygen saturations and titrate the flow up and down to try and maintain saturations of around 90, while at the same time minimizing the amount of oxygen that you're using. Oxygen concentrators should, according to WHO, produce at least 82%. Now we find oxygen concentrators flooding the market. We are sourcing them from wherever we can, and some of their qualities are suspect. Some of the concentrators claim to produce 93%, but that is only when the patient is on 1 or 2 liters per minute. The moment you go up to 5 liters, some of the small devices, the FiO2 plummets down to as low as 30% oxygen. So generally, I tend to believe devices that weigh at least 20 kg, and they should state that they provide 90 plus or minus 3 or 4% at the extremes of flow. Then these devices are quite noisy. Try and get ones that are less than 50 decibels. Most of them that we have are in the produce noise in levels of 40 decibel range. And some of these devices come off with auto shut-off timer. So be very careful because these increase the likelihood of errors. So preferably buy ones which don't have these auto shut-off timers. So to summarize, it's important to give oxygen, but at the same time conserve the oxygen. To give oxygen appropriately, we need to understand the concept of peak inspiratory flow. To minimize the oxygen we're giving, we need to understand the concept of minute volumes. Try and keep the oxygen saturation around 90%. I have pushed things further based on studies done on people who have climbed Mount Everest. So people who climb Mount Everest have shown that as they go up, they tend to compensate. The first way they compensate is by high minute ventilation, and the treatment. And as they climb higher and higher to Mount Everest, they carry oxygen, and their oxygen runs at about 2 liters per minute, and they have a 500 ml reservoir. They cannot carry huge oxygen tanks because they can barely move. And at the top of Mount Everest, people claim that you have to take 10 breaths to move every step. So they are using oxygen at about 2 liters per minute with a 500 ml reservoir bag. The closest one that we have is the NRBM mask, which needs to be used preferentially for the ones that are sick but not so sick enough to need either CPAP or invasive ventilation. So conserve oxygen. It's a big concern right now. And thank you very much for listening to me. And